Good afternoon, everybody, and welcome to today's webinar on Beyond the EHR, Connectivity That Counts. My name is Monique Dever, and I'm the moderator for today's presentation. Sorry, our system is moving just a little slow, so my slides are not advancing quickly. Just bear with me. Okay. There you go. So today's presenting is Tom Power. Tom is the Director of Business Development here at Patagonia Health. He has been in the industry for well over a decade already and has compiled some really great information into this webinar. This content is really the true distinction between what an EMR is, which is simply digital version of paper records, and an EHR that connects you to a whole host of other healthcare providers and IT services, as you'll soon see. Tom's analogy he likes to use is that EHR is the foundation of your house. And as we lay the foundation for the EHR, now we can build upon it. And so I'm going to add a little bit to that and say that in today's world, we want to build a smart home. So before we get started, I just want to mention that all of you will be in the mute mode during the presentation. If you have any questions, you can simply post them in the questions chat box on the right-hand side. You can shrink that box at any time in that little red arrow at the top and then expand it as you need to. So before we get started, make sure, Tom, you can hear me okay? We're going to go ahead and transfer the slides, change the presenter to you.
Yep, sure can.
Okay, great. Let's see. Bear with us for a second while we switch presenters. You have it, Tom?
Yeah, and you guys see my slides okay, Monique?
Yep, I can see it fine on this end.
All righty. Well, good afternoon, everybody. And first, I want to say we appreciate Patagonia Health. We appreciate it very much, you guys spending an hour of your day with us. And we do these webinars. We both have customer webinars that we do for our customers, which is kind of training on our products and services. But then we also want to be a good corporate citizen and also believe in the industries we serve. So purpose of my personal goal for this one is something I believe in. And I hope at the end of this, one, I at least give you some food for thought. Hope you learn something that you didn't already know. And then at a minimum, I hope you at least have kind of water cooler discussions internally. So hope that food for thought, you guys think about, hey, I saw a webinar and something to think about. So that's kind of my personal goals for this. It's something I believe in. The EHR is just really the foundation for the house. And again, we appreciate you guys spending an hour with us. So I'm going to date myself, and I started in healthcare IT in 1994, and really everything was green screen. To get a report, we had to run, the green and white paper, and our connectivity was a modem. So the young people may not remember this, but that was basically the interesting thing back then. Was that server in the back room that ran the Unix operating system that just did our billing cost over $50,000, $100,000 just for that box in the back room. So, as the saying goes, we've come a long way. So I thought we'd start with just where we were in healthcare and then kind of move into the connectivity. So before our Meaningful Use and the High Tech Act, which, by the way, all the EHR and EMR came out of, was actually the stimulus part of a stimulus program for meaningful use. Is really all the systems that behavioral health, public health, FQHCs, it was really just a management billing systems. There weren't really any standards other than billing. We were printing off HCFAs with HIPAA, by the way. Is where the electronic claims came from. That was actually pre-ARA. And how we stored data in our systems, it was just all over the place. It really wasn't structured data, so it was hard to get the data out. Basically, record enough information in the system to get me paid. And that was really the whole purpose of it. We didn't think about sharing data with other healthcare providers in the community. We didn't really think patient focused. It was more episodic care. And we know, as a national thought, we really didn't think about lowering costs other than the electronic claims on the billing side. So if you didn't know, all the electronic claiming actually came pre-EMR, EHR under HIPAA, which, if you remember, HIPAA stands for Healthcare Insurance Portability and Accountability Act. So that's where the electronic claiming came out of pre-ARA. So then the federal government came up with, as part of the stimulus package, an incentive program to incentivize all healthcare companies, or healthcare providers rather, and IT companies in healthcare to move to certified systems, to build standards. Now, there are always IT standards, but actually let's pick some standards for the United States. And they came up with a whole certification program, and there's 3 stages of that, by the way. There's also, if you're not aware, there's also multiple different kinds of certifications. For example, modular, you can buy an e-prescribing system alone, just e-prescribing, that's modular certified, or something like Patagonia Health, or a complete certified EHR. The other good thing, part of the HITECH Act, is there were national standards for security and privacy. We pick standards that are actually higher than banking for our healthcare. And then the big push, and what this webinar is mainly about, is talking about structured data and interoperability and sharing data across the whole healthcare ecosystem. And as Monique said, I believe, and this is kind of my passion, I believe the EHR is really just the foundation for a complete healthcare IT ecosystem within your agency. I mean, it's just the foundation of your house. And it's important you have the right foundation, but it's just the start of healthcare and where we're going. If you think where I started in 1994 versus 2009 when certified EHRs were coming out, to 2018, just where we've gone from 2009 to 2018 in 9 years nationally, it's huge. Hospitals, they report about 88% of all hospitals have certified EHRs now. Our social services side is a little lagging. I think it's about 50–60%. But huge gains we've had in the last 9 years. So one thing we're seeing, our CEO was at Open Minds a couple weeks ago. We've got staff at HIMSS. If you go to National Council on the behavioral health side, or on the public health side, APHA or NACCHO, you keep hearing about integrated care models. And we're seeing in rural areas, for example, we've got a customer, just using some of our customers as examples, rural Appalachian area. There's no Medicaid providers in the area. So that public health department did it their own FQHC. We got a call from somebody in Utah that's a behavioral health agency, but they also do primary care because they do residential. So the behavioral health agency formed an FQHC. We're seeing up in Michigan, that I've been personally spending a lot of time in, the public health departments are doing primary care for teen clinics and adolescent health. And then rural Maryland, another one of the areas I personally work, there's no community mental health centers out in rural Maryland, out on the shore. So the health department's also the behavioral health agency. So keep that in mind. If you don't have a solid foundation, you really want to think about, where's our agency going? What are we doing? How's it growing? Are we in a rural area? Are we in an urban area? All of that affects it. Patagonia Health, we've been exploding. I joined Patagonia Health 4 years ago, a little over 4 years ago, and we were in 1 state. We're in 21 now, just because we support those models. Whatever EHR foundation you have, make sure you're set up for the future. My little tidbit point for the day. So why talk about the house on top of the EHR? So with the foundations of the EHR, really the number one goal improve patient care, also improve patient satisfaction. With Facebook and all the social media out there, if your patients aren't happy, the world will hear about it. And it's not just your little area. They put something on Facebook, the world may hear about it. So patient satisfaction, keeping your patients coming back too. Reduce errors. So the more we can do from staff errors and reducing errors in healthcare, we don't, on the social services side, feel so much in surgeries and that kind of thing that can result in death. But on the other hand, reducing errors, somebody's allergic to penicillin and you give them penicillin for a STD, you can cause issues. So reducing errors, improving staff productivity. So the more we can do to improve productivity, the better. You guys grants are being cut. We'll talk about it a little bit in a minute. Things are being cut, so you're asked to do more with less. So if we can improve staff productivity, we should really think about it. Reducing costs, again, part of that productivity. And then the most important thing is payers and funders getting paid. If you don't get paid, you obviously aren't going to keep the doors open. Kind of doing my little flashback thing. Years ago, behavioral health, public health, I'm on the left side of my screen here. You got big grant funds, and it was kind of go out in the community, take care of the community, the big grants. You had some basic state reporting, not real heavy. You might bill insurance. Years ago for public health, behavioral health, didn't really bill private insurance. It did some Medicaid billing, but it was mostly grant funded. Well, circa 2018, public health got Title V, Title VIII funding with all the reports like FPAR reports for family planning. The FQHC have UAS reporting and different home care reports if you're doing home care services. The state and federal reporting are just constantly increasing. If you, under the meaningful use, you've got reports you've got to do to the local Medicaid agency, or the state Medicaid agency rather, annually. So you need all of those reports in there. And now we're starting to see hundreds and hundreds of smaller grants, like a grant for tobacco cessation. So it's got its own reporting requirements. All kinds of different smaller grants. It's not the big block grants to keep your agency open. It's, hey, tobacco is an issue. Let's, give grants out for that. Private insurance has changed a lot with the Affordable Care Act. Folks are under higher deductibles. Just telling a little story. If your EHR doesn't have real-time eligibility check, I went in. By the way, I'm getting over pneumonia. My doc office, which doesn't have real-time eligibility check, spent 25 minutes on the phone to find out I had a $20 copay with my private insurance. So, keep some of your billing stuff in mind as we go through this too. If you're billing with Medicare, macro, MIPS, all kinds of different federal stuff coming down the pike. And big thing, I put it in red that you're hearing more and more, pay for performance and outcome measures. So our tax dollars, which funds Medicaid, Medicare, what are we getting for our tax dollars? So you're going to be asked more and more, pay for performance, outcome measures. So really accurate data reporting, more important than ever. The other thing all of you guys are dealing with, depending on your agency, is accreditation. So this is something that's become huge in the last 5-6 years or so. So on the public health side, we've got the Public Health Accreditation Board. This came out of a North Carolina initiative where we've got about half the health departments use our software. They had an accreditation and it grew national. So now there's a Public Health Accreditation Board. You might be accredited if you're a health department. If you do primary care, or even some health departments are getting JCO accredited. I know some of our customers in Maryland are JCO accredited. And then if you're a behavioral health agency, CARF, big push for CARF accreditation. And I'm sure there's other ones out there. One of the big part of accreditation is they ask that your data be quantitative and qualitative. So really, you need structured data in that foundation of your house and be able to report on it. So the good news, you saw that green paper when I started in healthcare IT. I'm going to use some examples from Patagonia Health just because it's easy for me to get to. But dashboards and reporting tools are much more sophisticated. So if I'm a health officer at a health department, I'm an executive director at a behavioral health agency, or an executive director at FQHC, I can just look on a dashboard. What's my revenues? What's my charges coming in? I don't have to run a big report and sit and analyze, pages and pages of reports. So I can real quick, the CFO, take a look. This is just an example of our management dashboard. So the reporting tool is much more sophisticated, and at a glance, you can see what's going on with your agency. If you're under meaningful use, this was for stage 1, by the way. Are we meeting the thresholds for all of those meaningful use measures? Quick, at a glance, take a look. We can improve it, and I know, hey, 4 out of my 10 on stage 1, we got a problem. You CFOs and fiscal officers, there's dashboards available in billing systems. What's going on with claims in our agency? What are our payers doing? How many claims? How much we've been paid? How many rejected claims do we have? So all of that in the system. Reporting tools, I think, are hugely important. You guys really think about the reporting tools in your system or the built-in dashboards. More and more you're going to be asked as time goes on to look at that sort of thing. And we've got customers then, you've got all this structured data now, and most of you are county agencies that are on this webinar, I know. You own a software, which is a mapping software called Esri. ArcGIS might be the product name you know it by. So I grabbed a couple of examples from our customers in North Carolina. They want to map out syphilis cases. So your EPI folks can sit there and map out, is there anything going on? Is there any rhyme or reason to the outbreak of syphilis cases? So breaking that, taking EHR data, let's pull it in a map, and we can look at it. Easier than just seeing by zip code, how many outbreaks of syphilis, for example. And then you have business decisions to go with it too. So based on, we did a flu clinic last year, we gave out flu shots. So what's the flu diagnosis? Was it worth buying the flu shots and doing those flu clinics? Did we not do in a certain area a flu clinic, and then there was an outbreak of flu? So hey, this year we should look at doing a flu clinic in the southeast corner of the county. So really making business decisions based on mapping. It's a lot easier if you just see it on a map versus looking at raw structured data on a report. A lot of you on the webinar are health departments. So you go to a county board meeting and they're in a discussion about, should we build more sidewalks? Should we spend more money in the county on sidewalks? Well, you might have one of those board members look over at you, Mr. Health Officer, and say, so what's your take on, should we build more, sidewalks? Well, you can actually take, this is a customer took the obesity BMI data out of the EHR. They also combined it with the public works sidewalk area. So they pulled out of 2 systems and they overlaid it. And so you see in this area where there's huge sidewalks, the average BMI was 18, over here was 38. Just giving an example, no sidewalks in this area, 42 is the average BMI. I mean, you can put other stuff into it, but showing something like this to your county board with data can help decision-making moving forward. There's other tools out. We've got a tool called the Healthcare Analytics Platform, but your epidemiologist, your different folks that look at data, there's advanced tools, statistic tools that are on the market that you can drill that data in the EHR. We offer a service where you can kind of unload the EHR data, because because we're cloud-based, into your own database, and then you can run tools like SPSS against it. You can really look at analytics, and you can really combine that data, take a local copy of your database that you host from the cloud, and really munge that data, really look at it. So there's tools out there. This is ours that's embedded, but there's all kinds of different tools like SPSS out there on the market. Epi folks love this in public health. So how do you get away, talking about some interoperability, talking about connectivity. So you move to an EHR, hopefully you're doing everything electronic, those paper charts go away, but you still got to deal with the rest of the world. So there's fax servers that can be built into EHRs. We have one built in. Think if you get a court order from, say, the juvenile court to send a complete patient chart over for a teen. You could be talking to that clerk at the courthouse and say, hey, do you have a fax? Can you stand right there? And right from the EHR, you can just fax over a complete copy of their chart if it was from a court order. So you're still going to be dealing with outside agencies, outside things like courts, schools, where somebody might have a court order to get a copy of that complete chart. You can just send it right away. Don't have to print it, don't have to hand it to a courier, don't have to drive it down the street to the courthouse. Boom, it just sent right over. So kind of some old school technology make your life easier. So really the EMR is the hub for your connectivity. We'll talk about a lot of different things that's on this chart, but really in the center is your EMR. And then you've got different interfaces across the ecosystem of healthcare. And we'll kind of touch on each one of these as you move forward. There is capability now, and there's national standards like HL7 for healthcare connectivity to connect to other healthcare systems. So really, I tell everybody the answer is not no with healthcare anymore. It might be how big's your wallet, so it might be expensive, but really the answer is not no anymore with healthcare and exchanging data, interfacing to other systems. So really the answer is yes, and does it make a good business decision to do that? Talk a little bit about hardware. You talk about errors. I don't know if everybody's aware of this or not, but the CDC, I guess about 6-7 years ago, put the 2D barcodes on all the vaccines. So the old cereal box barcode, you could just get the lot number. That was pretty much it off of it. Well, now with the 2D barcode, you can get manufacturer, you can get lot number. So now your staff aren't going to transpose a number. They're not going to, boom, pop the vial, and it pulls right up in the EHR. So really talk about hardware connectivity. These things cost about $200 a piece, roughly. So really cutting down on the error. Talk about speed, patient satisfaction, signature pads, like for consent forms, somebody's up front at the front desk, they can sign right there. You're not having to keep a printer at the front desk, or maybe you do have a printer and you just hand the patient their copy that's already signed. So really improving patient satisfaction, cutting down on the paper you've got to keep. So all those consent forms are stored right in the EHR with the patient's signature on them. Scanners, you're going to get referrals, you're going to get different information from other agencies. I always recommend everybody ought to scan and upload a copy of their insurance cards in case somebody transposes a number. Your billing folks have that insurance card right there in the EHR. But putting scanners up front has the data. My billing example, so if somebody messed up and a claim got rejected, they can go right there in the system, see a copy of the insurance card, Medicaid, Medicare card, and don't have to track down the patient and spend hours on the phone tracking down the patient. We haven't done this, by the way, but we haven't had a customer ask us for it. But also keep in mind a lot of the tools and instruments out there on the market, like Welsh Allyn is one of the big international companies. You can connect to EHRs with Bluetooth. If you've had a EKG lately, I had a physical about a year ago, and they just put little Bluetooth things on me, no wires, and all the data was fed right into the EHR for my local primary care doc. So we haven't done that, but because our customers haven't asked us, but do keep in mind You can connect to scales, you can height on the scale, blood pressure, Welsh-Allen and others have connectivity to EHRs. So if you're doing enough physicals where it would make sense, I'd recommend, you investigating that with your EMR provider. One of the big things, and this was also part of meaningful use, is immunization registry and HL7 connectivity. In all of the states that we're in, all 21 states, we connect to the immunization registry through that HL7 connectivity. If your state supports a bidirectional, one of the big parts of that is you can get their complete history downloaded to your EHR, and then when the nurse finishes doing the immunizations, click one button and it sends what you did today and what shots you gave up to that registry. Cuts down on double data entry. You don't have to have, the website upload, website screen for the registry and your EHR open. The other thing, I mentioned the barcoding. You can cut down on typing errors. And if your registry supports it, I know I saw we had somebody on from Kansas. Kansas's registry supports this. You can actually get the recommendations from the ACIP. Recommendations will actually come through that interface. So if your registry supports that, you can get that interface. And the other thing, many states support the inventory. Big thing about inventory, keeping track of it, is you need to split out VFC eligible and non-VFC eligible vaccines and keep track of your inventory at the state level. State wants to know for those state supplied vaccine what you did, so the interface can support that as well. I think most everybody is aware of this. There's the SureScripts e-prescribing network. And part of the e-prescribing network is a national network that 99% of all retail pharmacies in the United States are connected to. And part of all certified EHRs is you can send a history request to the SureScripts network and then do medication reconciliation. So if you're a health department and you don't send anything out to a local pharmacy, or you're a behavioral health agency that doesn't send anything out to a local pharmacy, you can still do the medication reconciliation, pull in their complete medication history. The other thing those e-prescribing systems do is they'll do your drug allergy, therapeutic overdose checking. So I gave you the allergy example. It'll check against allergies. You can print off the drug information sheets as well from those e-prescribing systems that are built into your EHR system. So that medication reconciliation, preventing errors. The other thing, think about, say you give somebody penicillin for an STD or an antibiotic for an STD, 2 hours later, and you send it out to a local pharmacy for them to pick up. 2 hours later, they show up in the emergency room at the local hospital having issues. That emergency room and that hospital can query the SureScripts network, see that you gave them an antibiotic, and then probably realize that they're having a reaction to that antibiotic, and one, quickly diagnose the patient, two, resolve the issue, and not do 100 tests trying to figure out what's wrong with the patient. So big thing on the SureScripts network. I think one of the big gains we got as a nation as part of this whole EHR initiative with our own meaningful use. So the other thing, if you do a lot of labs, I know public health does a lot of lab, behavioral health agencies do a lot of labs. I put a few that we connect to up here on the screen, but there's hundreds and hundreds of lab companies out on the market. One of the big things, you can get your results downloaded from that lab company into your EHR. And some of the labs like LabCorp support bidirectional, so you can send the order to LabCorp and then they'll send you the result back. So it's a bidirectional interface as well. Cutting down on typing errors. And big thing with this, if you do hundreds of labs a week, you can huge productivity improvement. One business thing to think about, if you've got a small lab that you do 4 labs a week, it might not make sense to implement that connectivity with that lab because it's so low somebody can just hand key it in. But if you're doing a lot of labs with a certain lab partner, do talk to them about HL7 connectivity and getting your results. Sometimes if you do enough with the lab company, they'll even help fund the interface with your EHR as well. So talk to them when your contract's up with your lab as well. I think everybody's heard of these. It's an HIE, or Health Information Exchange, and all certified EHRs have to support the format to allow the interchange. And basically think of the HIE, which is in the center there, as a hub to exchange healthcare information. And so I come into the health department and it's connected to the local HIE, like in Kansas, so there's KHIN. Up in Michigan, there's Great Lakes Health Connect. I can query that HIE and get that patient's records all imported into my local public health EHR, like Patagonia Health. Or I'm seen for, say, a maternal program at the health department, but then I'm going to go to an OB. The OB out there in the community can use that HIE to connect and get the full healthcare records. One other thing to keep in mind, certified EHRs support formats such as the CCDA. The patients can also take that, say, on a flash drive. So there's requirements for you to give patients a copy of their data electronically, where you can import and export those formats amongst certified EHRs. Kind of sneaker net is the saying that goes, where, via a flash drive, your patient could come in with a copy of their records electronically from, say, that OB as an example. So one of the challenges with HIEs, for example, Vermont's been in the news, is funding for those HIEs. But say you want to connect with, you're a health department and you want to connect to the local community mental health center. There's no HIE in your area, and obviously you can't afford to spin up your own HIE for the area. There's solutions. This is just one we offer, called EMR Direct, where you can share data. It's secure, it's past high tech and HIPAA, and there's some other interoperability tests. This company supports about 30% of all the healthcare IT vendors that we do. This is like $100 a month type thing, ballpark. Don't hold me to the price. But in the system, you can share locally using EMR Direct, and it's all encrypted. You don't have to worry about HIPAA. You don't have to worry about sharing stuff over the internet. So there's other solutions out there on the market that allow you to share with your local providers if you don't have an HIE, or your HIE's having issues, or in some cases the HIE wants $10,000 or $20,000 to allow you to connect. The HIE's charging you, and it's not affordable. There are affordable solutions on there to share healthcare data across your local health systems. So I pointed out on the HIE real quick, you've got public health and all these different providers in the community. One of the big things that's missing, and this is a did you know, the local ambulance and all our first responders, I mean, how do you connect a local ambulance to an HIE? Part of the whole transition nationally to digital TV, Congress set aside some frequencies, spectrum, to build a high-speed internet mobile for first responders. They call it FirstNet, so for first responders, first network. And I just point this out because these guys haven't been part of the discussion of healthcare sharing data because there's been no connectivity. Ambulances use a little health care record, and they have their own standard. It's not full EHR, called EPCR, and they have a national standard. But you folks all work, most of you on the webinar work for the county. Really start thinking about we're going to have this connectivity. The ambulance, the fire, the police can have connectivity, high-speed internet, mobile. How can we include them in the healthcare infrastructure? Can we push something out? If I'm having a heart attack, can I push out the electronic records to the local ambulance? Not something Patagonia Health has done yet, because this FirstNet's something new, but just this is kind of a did you know, and hope you learned something on this webinar. So we talked about kind of beyond the EHR, and EHR being the foundation, and we've talked about some of this with EHR being kind of the center of your healthcare ecosystem, healthcare data ecosystem. Also keep in mind and think outside the box as you think about connectivity. Some of the examples I'm going to give are just food for thought. You may have, if you're a health department, you've got a local environmental health system. Well, in that environmental health system, you may take complaints. One thing we don't do currently in the industry, Patagonia Health hasn't done it, and we've got a lot of health departments, is take a referral from the environmental health system for a food complaint. Somebody got sick at a local restaurant, and have an electronic referral over into the EHR. Just an idea. Moving from environmental health systems into the EHR or vice versa. There can be interfaces to accounting systems. So if you're hand keying, all EHRs have kind of a patient ledger system. They do, I call it patient accounting. So it keeps track of all the patient level stuff. But at the end of the month, you've got, say, the county muni system or accounting package, and you need to do an export. You can actually do interfaces to those accounting systems, cut down on typing for your general ledger information. Case management and different third-party tools can be interfaced if they support those HL7 interfaces. We talked about analytics. Make sure you've got a good partner with your EHR. We're constantly building new things, working with our customers, and I don't think we're totally unique with as a healthcare IT vendor. It can all be done with HL7 messaging, web services, and all the different technologies that are out on the market. Just to give you an example of some of the things we've built with our customer, we've got a reminder system built into our software. And if you go out to PatagoniaHealth.com, there's a white paper out there on the amount of time saving that this did in the system. So it's an automatic reminder system that's built in. You can send it out in English or Spanish and send them a voicemail, text, or email. Just a reminder, cutting down on no-shows. So we've got white paper out there. I mean, huge, tens of thousands of dollars saved one of our customers by just sending somebody a reminder, hey, your appointment's tomorrow. And of course, you have to support confidentiality, and public health EHRs like ours does support that, by the way. Another thing, think outside the box. So you run a report out of your EHR, and bullet 2 there is, give me the report of everybody that came into the health department and got a flu shot last year. Say your results are 500 patients got a flu shot at the health department. One, you know how many vaccines to run or order for this year. But one of the concerns you have is, okay, we just ordered 500 vaccines. We can't return the vaccines. We need to, get the word out to the community. Well, there's outreach tools now are available for connectivity. We've got one built in, but just think if you could blast out to those 500 patients an email, text, or voicemail. It's that time of year for flu shots. The health department's doing a flu clinic. By the way, I live in a little town outside of Atlanta called Loganville, so I picked on my county and my town. But we hope you'll see there. So really doing outreach. The sky's the limit on tools like this. Patient engagement, if you go to any of those Open Minds or NACHO, engaging the patient in their healthcare, tools like this, connectivity like this, great tools that can cut down. There's no way you could sit there and have all your staff make 500 phone calls. I mean, it would just take too long. Even if you made, 20 calls an hour, you'd have to grab half your staff in your health department to make those 500 calls. Well, the computer can do it now. The other piece of, patient engagement, patient portals involving people in their healthcare, allowing them to see their data. Messaging tools where your patients, this is just a screenshot of our patient portal that's included with our EHR, but messaging where your patients can actually message the provider that's providing care to them. You can message your patient, and you're not worried about HIPAA and panicking about HIPAA. So I came in, got a bunch of STD tests. I'm in a panic because my wife's going to kill me. And you as a provider can type out, Tom, your labs came back. You're totally negative on everything. You're clear. The only thing I'm going to get from that messaging app is you have a message on the patient portal. Please log in to view it. But then I log in and I can see the message from the provider. So things that are coming back negative where you don't really need to consult with the patient, but the patient's anxious, you could do through something like a messaging. The other thing, seeing they can print their own health summaries, so people want to be engaged. They want to keep copy of their own records. There's also that CCD format, which if we've got any techies on the phone, it's an HL7 XML format that's importable and exportable to other certified EHRs. You can download that to, say, a flash drive right from these patient portals. So engaging your patients, allowing your patients to be involved. Mom can log into the, child's patient portal and get a copy of the immunization record and hand it to the school. So don't have a line out the door waiting on getting just a paper record if they're up to date on their shots. Just giving some examples of things for engaging patients and patient portals that we see with our customers. So really the next conversation you keep hearing about, if you read up on Healthcare IT Magazine, you read up on different healthcare journals, is population health. And really it's bringing everything, all the stakeholders together from local government, state, federal, the patients, hospitals, public-private practices in the system, and really bring everybody together for population health. And really we're still defining as a nation and as a healthcare ecosystem what population health is, but that's kind of the next conversation that's going on in healthcare right now. And then kind of finishing up, this was a slide I saw in an article I read, by the way. So think about connectivity and EHR. So you've got wearables. The Apple Watch can get BP. The Apple Watch can get all kinds of different healthcare information. So how is you going to use patient-level data in the future with your EHR when you're treating your patients? Telemedicine, for example, and if you're in a rural area and you can't afford to bring a local psychiatrist to your area, but you've got, a teenager with issues, can you use telemedicine? And we're starting to see that across the nation. You public health departments that do TB treatment. So you've got the direct observed therapy where you've got to view that patient being able to take their meds for 2 months straight. Well, can we use video conferencing to send the patient home with the meds and do the direct observed therapy for TB treatment, for example, using telemedicine? Looking at analytics, so you've got the HIE, which is the hub. You're epidemiologists, so we start looking at connectivity to the local HIE and looking at population. De-identify the data, so you're not looking at individual patient data, you're looking at it as a whole in the population, but getting that HIE data and really doing analytics against it. Care coordination and multiple providers and referral systems, part of Meaningful Use 3, by the way. If you haven't upgraded the Meaningful Use 3 software yet, we're finishing our certification for Meaningful Use 3, is the whole referral management, referral tracking, follow-ups, giving your providers dashboards on the system to be able to follow up with whole care coordination. Hey, I referred you, and it's also the social services side too. So I referred you to Medicaid, the local Medicaid, or I referred you to the local HUD office. Did you follow up? Did you go? And keeping track of that in the patient chart. Really not medical, but it's also following up on kind of those social things that we do beyond just medical in that whole human services, social services medicine. Another big talk is how do we get patients to take their meds? I mentioned TB, STD, same thing, any communicable disease. If you're doing any kind of opioid treatment, how do we get our patients to adhere to taking their meds? There are systems out there. Everybody's thinking about it, from Apple to Microsoft to Google. How do we have tools that we can engage the patient and verify in the system? There's one company that for diabetes, that the diabetes machine where they kind of prick their finger will actually upload to Microsoft Health Vault, for example, and then the providers can go in and review the insulin levels or whatever, help work with the patient on what insulin treatment they should be doing. So all kinds of different tools out on the market. And with that, I promised 1 hour and leave time for questions, and we're about 10 minutes till. Again, my name's Tom Power from Patagonia Health. If you have any questions, my email address is up on the screen, my phone number, anything we can answer, or if you just like to chat. I kind of love this stuff. Been doing public health and behavioral health software and working in the IT side. If you have a thought you'd like to share and just kind of chat about, my phone number and cell number are up there as well. And a shameless plug, if you're looking for an EHR and you're in public health, behavioral health, FQHC, Patagonia Health, I'd encourage you to go to our website. There's videos out there. There's training, different information. I don't believe we have any customers on this webinar of ours, but if you're out looking, please do keep us in mind as you look throughout the system. With that, Monique, I think, was monitoring the questions. If you guys have any questions, the chat box, you can type them in, and I'll let Monique kind of jump back in here, see if there were any questions.
Thanks, Tom. So I just had a couple of quick comments for you. I was kind of chuckling to myself when you mentioned about your 20 minutes waiting to find out what your copay was. I think your doctor needs a good foundation to build, huh? So,
yeah, I was talking about the foundation of the house. Make sure you've got real-time insurance eligibility checking. But I waited in the waiting room. 2 weeks ago, by the way, I've been traveling. I came down with pneumonia, so I got to go to the local doctor, and it took them a while to figure out what my copay was. And I was so sick, I told them, here's my American Express card. I don't care what the charge is.
Right. And then on the other thing I wanted to address was the bidirectional capabilities between the labs and the immunization registries and your EHR. Can you just clarify a little bit what the requirements on both sides, the EHR side and the lab or IR side is, just because they don't all do it, right?
Right. So an EHR can support what's called a unidirect with a immunization registry. So there's two types of interfaces, and it really depends on what your state immunization registry supports. So you may hear the term unidirectional, or AKA one way. So basically what that is your EHR, when your nurse is done giving the shot, she clicks a button and the EHR will upload what you did today to your immunization registry in your state. Many of the registries support what's called a bidirectional interface. And so before you start treating the patient or giving them their shots, you can download the history. The nurse will do the shots, and then she'll click the button and upload. So it's bidirectional. It's basically give the EHR information, and then the EHR sends it to the registry. When they're bidirectional, they also usually support your inventory, and they also support that it would have to be bidirectional to get the ACIP recommender. I know we have one person from Kansas on here. Kansas registry is bidirectional, and it supports the recommender, so it'll tell you which shots you should get the patient. As for labs, it just depends on what the lab supports. So you can have, AKA, a unidirectional lab, and that is the lab feeds you your results and you can import them into the system, or what you call bidirectional. And what that does is the EHR sends the order to the lab, so the lab knows that there's a specimen inbound, and then they can tie that specimen to the results and then send the results back to the EHR. It really just depends on what your lab supports. Tidbit, if we've got public health folks, state labs are notorious for not having interfaces. And so as you guys go to those state public health meetings, I would highly encourage you to kind of keep knocking on the state lab's door and ask them to support those HL7s, because the health departments do a lot of labs with the state lab. I only know a couple state labs that support that interfacing via HL7.
So I'm going to piggyback on that comment, Tom. If we, so say an agency out there has wants to migrate from, say, a legacy system, EHR system, to our system, for example, can they bring some of that data in from the lab and import that into the new system? In your experience, what have you found?
So data conversion is usually customized, and I can speak to, I've worked for a couple of vendors. It really depends on how the data is stored in your legacy system. I'm talking to one in Michigan that it's an old COBOL system, so can they get the data out? So it's an old COBOL system, it's a green screen system that we're talking to. So can they get the data out? And then is there a place in your new EHR to import it? One thing to keep in mind, we've had customers with issues at Patagonia Health, we've had customers with issues of can't get the data out, but they can print off and save a PDF. So we've got a file cabinet in our system. I call it patient file cabinet. Maybe you can print off something, print the PDF file, and maybe you can upload that legacy data. It's not structured, you can't report on it, but at least the nurses and the providers and the licensed social workers can have that history in PDFs in the client chart. It really depends on your old system, can you get it out? And then system like Patagonia, is there a place to store it?
Okay, that's good explanation. Thanks, Tom. So in other words, all EHRs are not created equal, and so the data will need to be formatted to a certain degree before it can be imported?
Correct. So and then you've also got to think, IT's involved in this. I won't go too geeky on you, but if your legacy system stored gender, say male and female, as 1 and 2 in the database, and now we're dealing with multi-gender, we're dealing with gender at birth versus gender identity, you've got to kind of help with the mapping too. So systems like Patagonia Health that are designed for the social services marketplace, we keep track of those gender identities and gender at birth, and because of all the federal reporting and everything, so your IT folks have to work with, if it was Patagonia Health, you have to work with our IT folks to kind of do that mapping and, hey, is this gender at birth because it's a legacy system, or is this gender identity, for example? You probably do gender at birth, using my example, and then when the patient comes in for the first time on a new system like Patagonia Health Foundation, you would ask them their gender identity, for example.
I have one last question. You mentioned EMR Direct, which is basically a direct message feature. Do all EHRs have that, or is it something that
for
basically
EMR
bypass? Right? It's basically so you can bypass the HIE hub, correct?
Correct. You get many rural areas that don't have an HIE. The HIE's failed. the HIE's in a flux. But there are tools out there like EMR Direct that we support. EMR Direct, according to their statistics, support 30% of certified healthcare IT companies. There's other tools on the market. The one we support, EMR Direct, basically allows you, and I use the example, you've got an FQHC in town, you've got the community mental health center, and you got the health department. Hey, we're all county employees. Let's all come together and let's share data amongst ourselves. Where you could use a tool like EMR Direct to exchange those patient records securely, HIPAA compliant, for hundreds of dollars a month versus, buying an HIE software that would be six figures, for example.
Okay. If anybody has any questions, as Tom mentioned earlier, go ahead and put those in the questions box. But clearly, there's an explosion of the wearable products and everything else that's going to be attached to the data import. You got the epilepsy watches, and you've got the quit smoke lighters that tells you every time you light up, and it connects to the EHR data. It's all very interesting. So again, to have a good foundation is very important. Because I think it's going to explode in the future with telehealth and all the other things coming our way. So as we're going to wait, we're going to hang on for a few more minutes if any more questions come in. But in the meantime, we do have a couple of future webinars that have been scheduled already. The first is to combat opioid crisis using EHR, GIS, and wastewater sampling data. That's going to be on Tuesday, April 3rd at 1 p.m. Eastern. It's going to be co-presented by Michael Bajorek, he's the Deputy Town Manager of the Town of Cary, and Sonali Lunia here at Patagonia Health, who is one of our co-founders and the VP of Customer Experience. The next one after that is called Outcomes and Measures, and that's going to be presented on Tuesday, May 8th, and also on Friday, May 11th for convenience, both at 1 p.m. Eastern, and that's going to be presented by Scott Levine, who's the Health Director here at Franklin County Health Department. So we'll be sending out email notifications on those as well, and with the registration details. So again, if you're interested in our future webinars, and they're pretty good topics coming up. So we've got no questions in the posting box. We'll hang out just a couple more minutes. Again, as Tom said, if you have questions post the close of the webinar, feel free to reach out to us either at Tom's email or at info@Patagonia Health. Either one will work. This was recorded, so if you'd like to watch the recording or share it with your coworkers, you're welcome to do that too. It's the same registration link that you used to register for today's webinar. Anything else to add, Tom?
I would just like once again to thank you very much for spending an hour with Monique and I today. We very much appreciate it. I hope we met my goal of giving you some food for thought. You learned something, or at a minimum, you get some kind of, hey, I saw a webinar, and start some water cooler discussions. So we very much appreciate it at Patagonia Health. I appreciate you taking an hour out of your day to spend it with us.
Great. Thanks very much, Tom. Thanks, everybody, for joining us today. Hope to see you on future webinars.